Well, it's 5 minutes after the hour. Welcome, everyone. I'm Richard Moore. Eileen Scully had a conflict today and was unable to be here. Looks like we have about 22 or 3 people who have joined. Hopefully, there will be a few more. I don't have any, like Eileen does, I don't have any specific announcements to give you today. And what we're going to be talking about today is a resource that's here available at Hopkins, which is called the Johns Hopkins HIV Clinical Cohort, which has been around for a number of years. We have 2 speakers who are really going to be, for the most part, presenting. Todd Fojo, who's an associate professor of medicine in general internal medicine, and Joe Hwang, who's a postdoctoral fellow also in general internal medicine. I'm going to start things off today. Let me share my screen. And hopefully everyone can see that. During the presentations, particularly for Todd and Joe, I'm going to do my best to monitor the chat for any questions that you might have, and which we can attempt to answer, I think, as we go through the talks. As I mentioned, we're going to be speaking today about the Johns Hopkins HIV clinical cohort. And I have 3 or 4 slides here of some history on that, since I was very much involved in the history of this particular cohort. And as you can see on the slide, I'm actually showing the results of the original study, which was published in the New England Journal in 1987, looking at AZT as the initial treatment that we had for AIDS and AIDS-related complex. And you'll see the relevance of why I'm showing this in just a moment. This was a randomized, double-blinded, placebo-controlled study of 282 people who had AIDS or AIDS-related complex. AIDS-related complex, for those of you who really weren't involved in HIV at the time, was kind of a precursor of AIDS. People who were sick in ways of having weight loss or oral candida and some other possible symptoms like night sweats or fever or lymphadenopathy, but had not progressed to an AIDS-defining illness. These were all people who had AIDS as defined by a first episode of pneumocystis pneumonia. And they were randomized to receive either 250 milligrams of AZT or placebo every 4 hours. The study was designed to go for 24 weeks. It was really a kind of a phase 2/3 study, because the only study that had preceded this was a study that was actually published in The Lancet a year earlier, which looked at 19 individuals given AZT, finding increases in CD4 count, decreases in virus levels, and improvement in clinical symptoms. So this was the first randomized trial. It was actually stopped early. At the time, 152 people had completed 16 weeks of therapy. Only 7 people had gone on to 24 weeks. And there was a remarkable improvement in both survival, getting new opportunistic infections, and improvement in the CD4 count. Why is that relevant? The reason is that this is a study that really kind of short-circuited the way FDA approved studies, such that it was a trial that really was started only after one phase 1 study. It was a very short-term study, and the FDA mandated that Burroughs Wellcome, a company that no longer exists, but was the manufacturer of AZT, do a phase 4 post-marketing surveillance study of AZT effectiveness and toxicity. And there were 12 HIV clinical programs across the US that were recruited into this study, and it was to be kind of a real world, real life use of the drug. Clinical trial showed a remarkable effect, but it wasn't clear in clinical practice was there going to be the same effect or similar, and particularly there was a lot of concern about adverse effects from AZT. The way these clinical programs were set up, there were basically cohort studies set up at these 12 sites. Clinical records were reviewed, information collected about diagnoses, AZT and other medications received, adverse effects of medications, and anybody from these sites was enrolled because they received AZT. And they may only have stayed on it for a short period of time, but the fact they were given AZT prompted them to be enrolled. And this study was rather remarkable in that it really was quite successful in looking at the much longer term than just 24 weeks safety and efficacy of AZT or zidovudine. A number of publications came out of it, and not just looking specifically at adverse effects and effectiveness. We were no longer looking at efficacy, but effectiveness in clinical practice. But other types of opportunistic illnesses that occurred along the way: non-Hodgkin's lymphoma, Kaposi sarcoma, pneumocystis, prophylaxis. As I said, it wasn't just AZT, but other drugs that were able to come out of this study. There were altogether about 15 or 16 papers published. This study ended after 2 years, and it was managed here at Hopkins. And it seemed reasonable to us, given how effectively we were able to do this study, that at least at one site, Johns Hopkins, maybe things could continue. We just didn't have the money or the outside support, at least at that time, to keep any of the other 11 cohorts. But ours was a particularly large cohort. And it was in 1989 that we actually continued what we were doing in that study with an observational clinical care-based longitudinal cohort, which was very specifically designed to understand the effect of treatment, not only AZT, but other RTIs that were then becoming available. And we knew other drugs were going to be available, given some of the early phase 1 research that was going on. And our aims were to characterize the clinical course of people in care with a focus on life expectancy and comorbidities, look at the uptake, utilization, as well as adverse effects and clinical outcomes of AZT, other new art, OI prophylaxis, and other management strategies, and evaluate other prognostic risk factors that were involved. And ultimately, hopefully, if things continued, to provide a resource for research on HIV and clinical care. And so that's how things started. I'm going to turn this over now to Todd to let you know kind of what has happened since 1989. Let me stop sharing, Todd, so you can share. Todd, you are muted if you're speaking.
Yep, sorry about that. All right, everyone can see my slides okay? Okay, well, thank you all. I really appreciate the chance to talk. Real quick, no disclosures. And then the goals here, what I'd like to do is just review the clinical cohort, give you a sense of what data we collect, the types of analyses we can run, and what we can offer. And what I'll do is I'll go through a brief overview of the data that we collect and who our participants are. And then I want to highlight 4 analyses, data points that we have done, one on substance use, one on race and social determinants of health, one on implementation of a rapid start program at Bartlett, and then one on the risk of diabetes that's associated with the switch to integrase inhibitors. The idea is here just to kind of give you a flavor and overview of what we do. So apologies, I won't dive deeply into any of these things. But with that, we'll get started. So basically, the participants or anyone who establishes care at Bartlett Clinic is offered or invited to participate in the cohort, and a majority of patients do. In terms of the data we collect or abstract all sorts of things from the electronic medical record. So really anything that is an epic and that is sort of a discrete data type is available, right? So that's things like diagnosis codes, laboratory values, radiology results, although, if it's text, it's a little harder to get at. We have pharmacy data, so prescriptions, when medicines are prescribed, when they're stopped, hospitalizations, and then social determinants of health. In addition to that data that is coming from the medical record, we also do a number of patient-reported outcomes. So these are at times when patients come in for clinic visits, our staff will grab them before or after the clinic when there's time and have them on a tablet fill out a battery of questions, psychiatric symptoms regarding to their substance use, stigma, quality of life. There's some adherence questions. We also have medical records reviewers who look through the medical records and abstract out specific things. So one of the things that they'll abstract out is substance use based on what's in the notes or in the clinical data in the medical record. We also link our cohort to death registries, right? So we have a good sense of when people die, disease registries. We keep a specimen repository. So once or twice a year, patients will give blood samples that then are banked and can be used in future analyses. And then we have a number of special projects. Ruben has one now where she, on a subset of our patients, does cognitive screening. So these are sort of all the things that the data that feed into our cohort and are aggregated. In terms of the staff that we have running this, there's 2 clinic research assistants who are the ones that you are most likely to have seen in Bartlett. They're the ones who, approach patients, new patients, consent them, are directing them to give blood samples that they do for the specimen repository, collecting the patient-reported outcomes. And then behind the scenes, we also have 2 medical records abstractors who review the chart, a project manager, a statistician, and a project administrator, as well as a number of faculty who run analyses. And just a quick overview on the specimen repository. We don't have to belabor this, but the bottom line is we have specimens on thousands of individuals and tens of thousands of specimens over the years. So in terms of the cohort participants, if you go back to the start of the cohort in the 80s, we have had 8,102 patients who have participated through the present day, reflecting the demographics that we're in. 76% of them are Black. Over time, this population is skewed older as the population ages, majority male. And then in terms of risk factors, about a third are men who have sex with men, a little more than a third. IV drug use was a risk factor, and then around half have high-risk heterosexual contact. And if you're looking over the life of the cohort, across all these years, about 66% of the time when you measure someone's viral load, again, going back decades, they are virally suppressed. If you look at the participants who were active in 2024, which means they had some contact with the clinic in 2024, a visit, a prescription, a lab, we had just over 2,000. So a little more than a quarter of the participants who've ever been in the cohort are active at this time. And those demographics are pretty similar, with the exception that there's not quite as many people with injection drug use as a risk factor nowadays as there are over the whole life of the cohort. And then what I wanted to do was make a comparison between all Bartlett patients, and actually this number includes some patients up at Green Spring and some of the satellite sites, so it's hard to make an exact apples to apples comparison. But if you look at all the patients that we had across Bartlett and some satellite things, it was 3,500. So we have about 2/3 of those are active in the cohort. And in terms of things that are different, right, the Bartlett population is a little bit younger than our cohort population, right? So we have fewer people at the younger age brackets in the cohort and more people here at the higher end of the tail. And then we continue to have in the cohort overrepresented people who have injection drug use as their risk factor for HIV. And this is just a geographic distribution of cohort participants. So the star there is Bartlett. This is the Baltimore area. And you can see, right, the majority of the patients are coming from pretty close to the clinic, but you have patients coming from sort of all around the Baltimore area. Obviously not shown here is patients who come from farther away. So that's sort of the overview of the cohort. And now I want to go into a few highlights of analyses that we've done. So the first thing I'll go over with you is substance use and some analysis we've done on the impact or the association between substance use and viral suppression. And we have two main ways that we assess substance use, right? One is that medical record review, where our abstractors go through the medical record, are looking through notes for mentions of substance use, or looking through lab results, indications on the urine drug screen, and they'll record any use in 6 months intervals: cocaine, heroin, alcohol, cigarettes. We've recently added fentanyl. The other way that we can assess substance use is with patient-reported outcomes. So these are structured surveys that have been validated. For heroin and cocaine, we use the NIDA Assist questionnaire, which says, have you ever used? If you've used, have used in the past 3 months, how often do you use? And then for Audit C, for alcohol, there's the Audit C questionnaire, 4 questions getting at, how often you drink alcohol. And these are done approximately every 6 months, right? They're scheduled to be done every 6 months, but because they're done when patients come in for clinical visits, and when we can squeeze it in, it's not an exact every 6 months, right? So it's on average every 6 months-ish. And obviously, if a patient misses visits for you, then we don't collect patient-reported outcomes, but we still abstract the medical record. So we can ask, all right, well, what effect does using cocaine or heroin or alcohol have on viral suppression? And to get a sense of how often people are using in our cohort, we grabbed 2,000 plus participants and randomly selected 1 month between the period of 2007 to 2015 and said, did they have medical record review that indicated substance use during that period? And did they report substance use on the patient-reported outcome? So you can look here, right? For cocaine, on medical record review, we have 10% of people in randomly selected months using cocaine. Only 7% of those reporting it, right? But you have 13% either, which means that there are some people who you're picking up with the patient-reported outcomes who are not on the medical record review, and some patients who are on the medical record review but are not reporting it on their outcomes, right? You can think about whether that truly represents that we failed to capture it, or it could just be the way that the time periods line up, right? It could be that, when the medical record review happens, they actually didn't have it in the past 6 months, but because the patient-reported outcome was a little earlier, they capture it. So this is not necessarily patients lying, right, or misrepresenting stuff. It could be recall. It could also just be the way the time periods line up. But anyways, if you take a positive report on either of those, 13% of people in our cohort using cocaine at any given month, 7% using heroin, and then hazardous alcohol use, almost a quarter. And then if we look and say, all right, well, what impact does that have on suppression, right? Or viral non-suppression, right? This was an analysis of subset of those patients, 1,500 of them, looking across time, and in a particular month, given that you reported recent use or not, what was the chance that you were virally non-suppressed, right? And so for cocaine use, 23% as opposed to 11%, heroin use, 25 versus 12, hazardous alcohol, 20 versus 12% use. So, you know, there is a substantial difference in the risk of being virally suppressed if you're using substances. And we've done a number of follow-up analyses to unpack sort of, you know, associations with other social determinants or demographic factors. But for the sake of time, I will skip that and move on. So the next project or data point that I wanted to highlight is we observed differences in continuum of care outcomes by race, right? And one question we have is, you know, to what degree might these be explained by differential adverse social determinants of health? We looked at two continuum of care outcomes for this. One is missed visits, or the probability that if you have a visit scheduled, you will miss your visit. And then two, durable viral suppression, by which you mean within a year were all your viral loads virally suppressed, less than 200. And the social determinants of health that we can look at is we have household income relative to federal poverty level, housing. And there's a number of questions to get at this, but we dichotomize it as either permanent or not, and not permanent meaning that you're living in a shelter or you're reporting unstable housing. Recent incarceration within the past 5 years, whether health insurance is public or private, where public is Medicare, Medicaid, or, you know, Ryan White support. And then we also have patients' locations to the resolution of census block, which are sort of aggregates of a few neighborhoods. And based on people's census block, you can calculate an area deprivation index, which is a geographically based measurement of socioeconomic deprivation in a neighborhood, or in this case, in a census block. So we did a study, 2023, 1,500 participants, and we had some assessment of social determinants. And of those overall, you know, 2/3 had public insurance. The majority are below 300% of federal poverty level. 11% indicated some unstable housing. 3% were incarcerated, and 55% lived in a area with a high area deprivation index, and a higher index means more deprivation. But there are differences here if you dichotomize Black and Hispanic versus white, right? With, in general, white people having higher incomes and less likely to be on public insurance and lower neighborhood deprivation. So if we then look at the proportion of missed visits, right, there are differences by race, right, with Black or Hispanic cohort participants more likely to miss a visit and slightly less likely to be durably virally suppressed. And if you run that through a model that adjusts for demographic differences, right, the Black or Hispanic group is 11 percentage points more likely to miss a visit and 5 percentage points less likely to be virally suppressed. If we then run a model that, also adjusts for those social determinants of health, right, area deprivation, housing, insurance, poverty, that effect attenuates, right? Now the adjusted difference is in the probability of missing missing a visit in clinic is down to 4%, and it just barely excludes the null, right? And the durable viral suppression effect loses its significance, right? So, you know, we're working on further analyses, right? But that at least suggests that a fair degree of this difference by race is explainable by social determinants of health. All right, I'll move to a third project. And this was an analysis we did that came out of program Joyce led to implement a rapid start and rapid restart program. So it's obviously not standard of care, but this was piloted in 2017 and then officially started in 2019, right? And it is basically making sure that as soon as the clinic is aware of somebody who either has a new diagnosis and is not on ART, or has been lost to care, has a previous diagnosis but is not on ART, that we get them linked up to care and start on antiretrovirals as quickly as possible. And that gloss obviously does not do justice to the tremendous amount of work it takes to make that all happen. But the questions that we want to say is, well, what did we, what did this do for us, right? Did viral suppression, do we get people virally suppressed faster? And then you could also ask, particularly for rapid restart in patients who've been, disengaged from care in the past, right? You could say, well, are there adverse incomes on continuum of care down the road? If you're just plugging everybody in, what are the chances that they're going to, to disengage in the future, right? And so, you could do that by manually going through the clinical records of all the patients who went through rapid restart and then try and find some comparator. Or what we did is try and figure out, well, within the people in the cohort, who are the ones who would have gone through the rapid restart program, and compare that historically against how people did in our cohort in the times before the rapid restart program. So what we did is we identified patients who were in the cohort who had their first visit in Bartlett Clinic between 2013 and 2023, right? And so that will give you several years before the rapid restart program, and then several years after, confounded by the COVID pandemic, since it's just temporal, and that's sort of inescapable. But we classified those people as newly diagnosed if their diagnosis was within a year prior to that initial visit, and previously diagnosed if their diagnosis was greater than 1 year prior. And we also said their viral load had to be over 1,000 to distinguish with people who were having their first visit in Bartlett, but were not previously disengaged in care, but instead, were transferring, right? You can have someone transfer, they still have their initial visit, they're not actually eligible for a rapid restart. And then we split those participants based on if they went through the rapid restart program. So everybody 2020 or later went through the rapid restart program, and then for the 2018 or 2019, we cross-tabulated it with the records that Joyce kept about which specific patients went through, right? So basically, everyone prior to 2018 does not go through rapid. Some patients who are in the 2018 and 2019 period go through rapid, some do not, and then after 2019, everybody goes through the rapid start or restart programs. And the outcomes we looked at were the time to ART initiation and viral suppression, and then also in the first year or subsequent year, what are the chances that they're retained in care, that they miss visits, and that they're virally suppressed in subsequent years. So the numbers look like this. We had 291 patients who were newly diagnosed coming for a first visit at Bartlett. The majority of them were in the time before the rapid restart program was eligible, but 58 went through the rapid start program. And then over that 10-year time period, 226 participants who were previously diagnosed but were establishing care and were unsuppressed at the time that they established care, and 25% or 25 of those, or 11% of them would have gone through the rapid restart program in that time. And so if we plot the main outcome of time to viral suppression, I'm a little colorblind, so I'm never 100% sure on the colors, but I'm going to go with light blue or maybe turquoise on the top here is the group that went through the rapid start or rapid restart program. And then the red line on the bottom is those who did not go through the rapid start and restart program, right? So you see, you get faster viral suppression among the new diagnoses by a little bit, although at the end, everyone catches up. For the previously diagnosed, right, you get faster viral suppression, and then there's this tail of people who before the program, well, there's some people who never get virally suppressed, right, but there's more of those people who never get virally suppressed in the time before the rapid restart program was there. If we look at that sort of more numerically, what I have here is the days until they're initiated on ART, and this here is the median and then the interquartile range. So what this is telling you is that for the rapid start program, 75% of people are initiated day of for new diagnoses, right? Prior to the rapid start program, a quarter of people, it took 28 days or more for them to be initiated, right? And there's a slightly significant hazard ratio, so a little faster in getting people started. How long does it take people to get virally suppressed among the new diagnoses, right? So a median of 39 days in the rapid start era as compared to 77 days in the prior to the rapid start era. That doesn't achieve statistical significance, right? Which probably, if you look back, these lines kind of coming together here, right? You see them get faster, but then the lines come together. If you look at previous diagnoses, again, in terms of days to ART initiation, the top of the interquartile range is 0 days, which means 3/4 of people are getting initiated same day, right? Prior to the rapid start area, you had a quarter of people who took a few months to get restarted from their initial visit. That is not significant. Again, you don't have a lot of people in the rapid restart arm, but in terms of how long it takes them to get virally suppressed, they're getting virally suppressed faster in the rapid restart era. And that is a slightly, again, significant hazard ratio. Looking then at the downstream continuum of care outcomes. Oh, geez, I chopped off something here. This should be retained in care, not days 2. So anyways, the bottom line, though, is that there's no significant differences between the two groups, either for new diagnoses or previously diagnosed, right? So no statistical significant differences in the odds of being retained in care, of missing a visit during that first year, or of getting your viral load checked or having a suppressed viral load in the subsequent years, right? So, you can take that for what it is, but at least you can say it is not that the rapid restart program is including a bunch of people who then are going to just fall out of care. And then for the fourth highlight, I will stop sharing and turn it over to Joe. Joe, I'll let you share.
Okay, thank you, Todd. Share this. All right, I'm going to talk about an example of a project that we've had at Johns Hopkins HIV Cohort as well. And the focus is a little different, that we're looking at cardiometabolic disease in people with HIV. And we're particularly interested in looking at the effect of antiretroviral therapy on adverse metabolic outcomes in the population. Just to give you a little background for folks that are less familiar with this area, we care about diabetes in people with HIV because it is projected to affect about 25% of people by 2030. And as we are concerned about cardiovascular disease that is becoming the leading cause of morbidity and mortality in this aging population, and the fact that they're on ART indefinitely, do motivate us to study the relationship between antiretroviral therapy and possible adverse metabolic outcomes. So people with HIV, is highlighted in the purple or magenta, are affected by the risk factors for diabetes from the general adult population with aging and increasing obesity rates, as well as some of the chronic HIV infection, as well as antiretroviral therapy highlighted in green can also contribute to some of the metabolic dysregulation that these individuals experience. And some of the metabolic outcomes beyond weight are not routinely assessed in clinical trials that lead to approval of these medications, where real-world studies are becoming increasingly more useful in studying these effects. So we'll focus on integrase inhibitor, which will be the main drug class that we'll present today, which is the modern antiretroviral therapy. And there has been pretty strong evidence in both randomized studies as well as real-world studies that establish a relationship between weight gain following integrase inhibitors. And there were subsequent real-world studies that came out several years ago that showed higher diabetes risk in people who are ART naive in the real world setting, and they get started on INSTI, and these studies compared against people that started on other core agents, and it showed a relatively higher risk of diabetes. What we were particularly interested in the Johns Hopkins HIV cohort was that many people, other than being a new starter on ART, they sometimes are being switched to integrase inhibitors, and these are a different population because they're ART experienced and wanted to investigate the risk of diabetes after switching to INSTI. So this was an observational study that we did, and we had the following eligibility criteria. So we defined the chronic user of NRTI or PI to have been using these agents for 6 months or greater within the study period, and we had people who did not have history of diabetes before because we were interested in incident diabetes, and we ensured that the incident exposure that the participants had were the first prescription of INSTI or exposure to integrin-based regimen. So we compared the switching, and I'll get to the target trial emulation in a little bit in the subsequent slide, but we compared two treatment strategies here. So one was to people that are switching to INSTI, which was one of these four agents, and against people that were continuing on NRTI or PI. So we were really interested in the switching effect and how in our estimation of risk of diabetes. And we defined diabetes using laboratory values as well as medication-based definitions and diagnosis codes. So as we alluded to earlier, we were interested in incident diabetes in people that are switching from older regimens to the INSTI-based regimen. So if you were to create a hypothetical randomized trial, you would design a trial where you randomize people that are on NRTI or PI, and you would randomize to switching to INSTI, or you continue on the current regimen at enrollment and you follow them forward in time for diabetes. What we did in our trial emulation was this was an observational study, and we had patients who were exposed to switching versus continuing at clinical encounters. So we anchored our study on HIV clinical encounters, where patients come in, they have the opportunity with their clinician to switch or continue their regimen. And we, similar to the randomized trial, we followed forward in time for new onset diabetes. We used nested clinical trials strategy as our target trial emulation. So this allows an opportunity to observe and follow patients at multiple intervals. So say you have a patient with HIV or taking NRTI or PI, and they come for a first clinical visit, they have the opportunity to switch to INSTI or continue. If you continue, then you have subsequent visits where you have the opportunity to switch, and the second, third, as going so forth. And then from those observations from these clinical encounters, then we follow the patients forward in time. You may be wondering why if someone switched to INSTI and they go back to NRT or PI and they go back to, and then they switch again. So we earlier on our exclusion criteria, we were interested in the first switch. So if you had been switched before, then you were excluded because then that is consistent with our criteria that you could not have a prior INSTI exposure. So we were studying the first switch, and we've accounted for repeated observations, at the analytic level. So we did it from the results that we had based on the participants in the Johns Hopkins HIV clinical cohort. We compared, again, people that switched to INSTI compared to the people that continued on RTI or PI. We had about 600 switchers and 2,000 continuers. And these individuals contributed about a total of over 20,000 observations to this study. And the hazard ratio we see a not statistically significant, about 11% higher risk of diabetes here. That is depicted by the cumulative incidence curve below here as well. Interesting things that we found were we wanted to assess whether weight gain, because weight gain is a risk factor for diabetes, whether if we were to account for weight gain in the first year after switch, whether that has an influence on the diabetes risk following the switch, but it did not. We also assessed whether the diabetes risk is concentrated in a certain period following the switch. And as you can see in the cumulative incidence curve, there's a separation between the switchers depicted by the blue and the continuers or non-switchers depicted by red. There's a gap you can see early on that do close up later on in the follow-up period here as well. So yeah, all right. So this has less to do with Johns Hopkins HIV cohort, but I just wanted to satisfy our scientific curiosity. What kind of happened after we published this study was that we had expanded the study and we brought the proposal to NA Cohort, which is a larger consortium of people with HIV that Johns Hopkins HIV cohort is part of. And in this analysis, we separated out the people that switched from PI and people who switched from NNRTI, and we saw that there's about 40% significant higher risk of diabetes among the people with HIV that switched from PI to INSTI. And we did not find such higher risk in the switchers from NNRTI-based regimens. Again, we were able to reproduce, there were no meaningful mediation by weight gain following switching, and which makes us think, what are the other potential mechanisms by which this higher risk of diabetes is occurring? And there are some clinical studies that show there are signs of insulin resistance with INSTI exposure even before a meaningful change or measurable body weight or composition changes have occurred externally, as well as some translational studies that show similar insulin resistance patterns, as well as other cellular mechanisms that could possibly explain this risk that we see. We also saw in the larger study that diabetes risk was still concentrated in the first few years after switching to integrase inhibitors. And this finding, could be explained by possible inductive effect, where in the immediate period after switching, where you have some residual effect from the PI, as well as you have some new effects from INSTI that could be potentially culminating to this higher risk of diabetes. But also, we've also seen these patterns of heightened risk in the initial period of exposure in other cohort studies of people with HIV across different continents that have investigated cardiovascular disease risk instead of diabetes and INSTI as well. So with that, I will pass on the button back to Todd.
Todd, you're muted.
Apologies again. All right, well, thank you all. Those were the highlights. And so we hope we've given you sort of an overview of the cohort and the kinds of things we can do. Sort of concluding thoughts here is we have a lot of data on a lot of participants over a long period of time. And in general, if it's in the medical record, we can probably get at it. Plus, we get patient-reported outcomes, vital statistics, medical record review. And our team has a lot of experience in longitudinal analyses. Historically, we've done a lot of work around viral suppression, substance use, and mental health. Are doing a lot of work nowadays too in non-infectious comorbidities, like Joe is doing, social determinants of health. And I think our pitch here is just that we're always open to collaboration. We would be pleased if you have thoughts. We can always do a quick peek at the numbers, right? It's, if the question is just how many people have characteristic X, that's something that we can answer very quickly. We're also open to sort of collaborating on more formal in-depth analyses. So thank you very much, everyone, for your attention, and I'd be happy to take any questions.
Nothing in the chat that Emily, or are you raising your hand, or I get clapping? I can't tell. I do want to mention, and maybe I should have mentioned as part of our history, a lot of people have been very, very important in starting this cohort and keeping it going over the years. It did start in 1989. There have been actually over 650 publications that have come out of it from right around 300 investigators, most of those ESIs, something on the order of 2/3. So it's been very been very productive in that regard. I want to give I think he's on this call, a special thanks to Dick Chason, who was very, very supportive in about every way possible at the very beginning of our cohort, and published particularly a number of I think what were pretty important studies early on. Joel Gallant as well, Greg Lucas, Mark Sulkowski, Kelly Gibo, John Bartlett, Shon Falade, and others who have published over the years in regard to not only necessarily HIV progression and outcomes, but a lot of the comorbidities that early on AIDS associated, but in more recent year, age associated that have been published. And we were also fortunate enough over time to become part of actually 4 different consortia. Now, 2 of those we started, and one called the HIV Research Network, one called the NA Accord, NA standing for North America, which we have been part of. There's another consortium called CENIX. The first C in that stands for CFAR, which we continue to be a part of. And so we've been very fortunate in that regard to have a lot of colleagues from across the United States who've been involved in what we do. But we're still going strong, as Todd said, and Joe said, and we welcome ESIs, but we welcome almost anyone to join us and bring your ideas to us. Dick.
Hey, Richard. Thanks for those comments. I just wanted to embellish on them because I came to Johns Hopkins from San Francisco General, where we had a cohort, and the number of publications that came out of that cohort over the last 40 years were exactly none until they joined the NA Accord. And everybody had a cohort and nobody published because nobody knew how to do it. And Richard is really the pioneer who figured out how to do this right and made the model that has been emulated, first by clinics around the country, then around the world, and culminating in the IDEA network that the NIH has funded. So it's really just been an extraordinary resource, and Richard's a true pioneer. And I'll also embellish on, the early stage investigators who have profited from this, starting with Richard and me and Jeannie. We were all early stage investigators back then, but Mark Sulkowski, Kelly Gibo, you mentioned Joel, Marshall Glesby, Emily Erbelding, so many people, Janine Mienza, got very important experience and contributed really important data from the Hopkins cohort. So for me, today, it's really thrilling to see that there's a new generation of early stage investigators who are benefiting and generating really important data. So, Richard, kudos to you for figuring this out long ago. This morning, medical grand rounds were Caleb Alexander, talking about pharmacoepidemiology, and as I recall, Richard, the Hopkins HIV cohort was the first NIH-funded pharmacoepidemiology study. So it's just pioneering in so many ways. So,
well, what Dick didn't just mention is that he was PI of the grant from AHRQ at that time called AHCPR that actually got that first study that kept us going. 1989, we were able to begin with a little bit of leftover Burroughs Wellcome money, some money we had from the state of Maryland, interestingly, but it was really that grant that launched us on to ultimately be funded by a number of NIH grants over time. But yes, thank you for mentioning that. And Dick was the PI of that.
yeah, and I even wrote a few lines of it.
But I think the point of showing this today, and I really appreciate Todd, who now runs the cohort after my retirement, and Joe for presenting that it's very actively operating. And it does have a huge amount of clinical data that continues to be collected. A specimen repository, which now dates back a couple of decades, but continues, and we're part of other consortium. And so we do welcome and very, very much invite others who might see some opportunities with this resource to please let us know. We're about at the hour, but is there any questions or comments anyone would like to make? I want to thank Todd and Joe for their presentation and Dick for his very kind comments. Okay, well, thank you all very much. I appreciate you attending. I think we're going to go back to our cases next week, if I'm not mistaken. Laura, you can correct me if that's incorrect, but I think it is. And Emily will Eileen will once again be hosting. So thank you all very much.
Cases next week.
Thank you.